Good morning, everyone. Grateful that you guys are all on. Today we have a pretty special lecture from Camilo Molina. He's out at Washington University and is neurosurgical trained
You
spine
know,
surgeon there, but also is and deeply involved in the orthopedic department there. He's been an awesome addition to kind of the faculty that's been going and teaching about several different things. One topic he's not going to cover today, but he's got a tremendous understanding of sagittal alignment, and has been, I think, really meaningful in us understanding that. But the other world that he plays in pretty heavily is this world of primary spine tumors, and I thought it'd be a great way to welcome him to our little family here and teach us about primary spine tumors, which I think in our neck of the woods is something that we don't deal with very often. And it's great to have you on board here with us, Camila, to teach us about a pretty important topic. Thanks for being here.
Thank you, Greg, and thank you guys for having me this morning. I'll get started. Really, the main topic here with respect to primary spine tumors is really how do we tackle these challenging cases? They're often challenging patient scenarios. We're talking to patients about potentially sacrifice of function to achieve these resections, and putting them at significant risk with the premise that if we're able to resect these lesions with a negative margin, their likelihood of recurrence is significantly lower. And a lot of evidence shows that their time to progression-free survival is significantly lengthened. So there's a lot at stake here, but there's also a lot of risk in taking this on, as you will see. So in order for us to accomplish this, we really have to put the right team together, constructing the team. We have to think about how we're going to deconstruct the tumor, and I'll go through an algorithm or framework that we've devised to do this. And then after these enormous destabilizing resections, how do we put together back the spine and the associated soft tissue envelope with it? So, as I said, the objectives of this talk present this framework for the en-bloc tumor resection planning, the assembly of these multidisciplinary teams to achieve our goals. And in doing so, we're going to talk about how we use 3D models to facilitate the surgical planning, talk about how we're using 3D models not just to plan the surgeries, but actually patient-specific 3D implants to reconstruct the spine. And then we talk about how we're pushing the limit on anatomical corridors to achieve these resections, and how we need an expert team of multidisciplinary surgeons to really accomplish this. So I'll start with a story, actually not of a tumor, but what got me thinking about how we could use not only 3D models, but 3D printed implants to reconstruct the spine. So this was a gentleman that I took care of early on in my career. He had a Charcot spine after a remote spinal cord injury from a motor vehicle accident, had multiple revisions with a T4 to the pelvis, and pseudoarthrosis at L2, and eventually his entire spine below L2, including the vast majority of his sacrum, disintegrated. He only had bilateral iliac wings left. He had a chronically open wound that would never heal because of the persistent motion, and his implants would progressively get spit out this kind of chronic decubitus ulcer appearing low lumbar wound. And as you can see, going from supine to sitting, the guy would more or less sink into his body like an accordion. And it got to the point that if he spent most of the day sitting, his organs would get compressed and he wouldn't be able to get any nutrition. And so he was really near the end of the road. Uh, and I felt that doing the same thing over and over again that had been tried before was likely not going to work. So I devised a method to reconstruct both his sacrum. We devised this thing that we call the sacral cradle, as well as an anterior lumbar cage that had this dovetail mechanism that would then dovetail into what we made a new sacral superior end plate for him. And I told him this was a little bit of a Hail Mary, but it was my best attempt to get this to work. And we reinforced it anteriorly and posteriorly with structural fibular autografts. So the execution, back, front, back, ultimately it was successful. And I only show this because I felt that this was a good case. I had a lot of time to plan it, but it allowed me to really prove to myself and to others who had previously thought that this concept of using these type of large patient-specific implants was not feasible for complex reconstruction. You can imagine this essentially is no different than having done a large sacrectomy for a tumor and reconstructing it in this fashion. In these cases where we do these sacrectomies, they're prone to mechanical failures on the long term, and we accept that. If the patient survived long enough and they have no recurrence, but they have a rod fracture, we say, oh, it's just, an oil change. You're lucky that your tumor hasn't come back, because it's very difficult to reconstruct these spines. So I extrapolated from this experience. By the way, here's his wound that eventually closed after an ALT flap. Published upon this, figured out how to use the IDE pathway through the FDA to get these implants to the patients through the appropriate legal regulatory pathways. And then not long after this, had the opportunity to take care of this young woman, 35-year-old female, large pelvic chondrosarcoma extending into the left hemisacrum and left hemipelvis. And inherently, you biopsy this. By the way, this is a plug. If you ever see a tumor like this, always biopsy it. Don't go in and breach the capsule and do some type of decompression surgery and then send it somewhere else, because by that point, it might be too late to actually do the en bloc tumor resection if the capsule's been breached. So we do the biopsy, proven chondrosarcoma. We plan this tumor, and we achieve the en bloc tumor resection, as you can see here. Complete left hemisacrectomy, left hemipelvectomy, a team of experts assembled to do this. But then we have this large bony defect. You have essentially no bridging bone from the inferior L5 end plate, and really no structure where to land good implants on that left hemipelvis. Then we have a very poor ability to transmit those anterior axial loading forces to the posterior column of the ilium, which is a function of the sacrum. What you're looking at here is actually just a temporary reconstruction after the resection, because we plan to do a 3D printed implant for this patient for this very purpose. And what these are the tucked in fibulas, which are vascularized fibulas, so, in preparation for the final reconstruction. So for this patient, we designed an implant that would bridge that inferior L5 end plate and would fit to the exact cut surface of that left hemipelvis along that posterior column of the ilium, which is has this greater structural component to it. And we designed the implant to have a little basket for the placement of allograft. And eventually we were able to get a successful fusion. And what you see behind here is the structural fibula bridging the dorsal aspect of the lumbar spine to the surface, the dorsal surface of what was left of the ilium. But one of the important things, and Greg touched on this earlier, is that I have a significant interest in sagittal balance, and the tumor world and the deformity world often don't marry with sagittal balance. And in fact, when we do these sacrectomies, we don't realize that we can actually completely change the sagittal alignment to these patients, because we inevitably change their pelvic incidence. And we really have to be thoughtful about where we put the pitch of their lumbosacral junction after these procedures, and it's something that we had never really thought about before. And the use of these implants actually allows me to not only plan the hand and glove fit of the implant into the remaining bony surfaces, but I also use the patient's preoperative Scoli films and attempt to at my best to match their lumbosacral anatomy and reconstruction of their spine with the 3D printed implant. And as you can see here, we are able to do exactly that. And this is her. She was about 6 weeks out of surgery here, doing well. One of the main criticisms that initially came out of this is that these implants take a tremendous long time to make, to design, to get back in the patient. You're not going to want to go back in multiple weeks later after everything's scarred in, etc. But while I acknowledge those limitations, I sought out and found a small company in South Carolina that has a intellectual property in a specific 3D printing alloy where they can essentially turn these implants around in just a few hours. So I had a lot of time to plan this original non-tumor case, but then I realized how quickly we could get it done. So from the time of resection temporary fixation, and then reimplantation of the implant here, it was only 120 hours, but we knew we needed to push the envelope a little bit more. So not long after that, had the opportunity to take care of this gentleman with a leiomyosarcoma. In this case, he needed a complete sacrectomy as well as a right-sided hemipelvectomy. Very difficult reconstruction. You essentially have no ability to transmit the forces from the anterior column of the spine to the posterior column of the pelvis via conventional reconstruction mechanism. So we designed them this implant to accomplish that. And here are his films. And in this case, we got a little bit better, and we're able to do it in 96 hours. But what about the other end? This is a gentleman who had a biopsy-proven C2, C3 chordoma involving the right-sided vertebral artery, exophytic into the retropharyngeal space. He was told that this was inoperative from an en bloc resection standpoint at multiple facilities, but we thought that if we could achieve an en bloc resection, that's what was ultimately best for him. But you can imagine that the reconstruction here is going to be somewhat difficult, given that the tumor needs to have the entire C2 vertebral body resected as well as the C3 vertebral body resected. And so you have no anterior structural support of C1. The structural support in C1 is going to be out at wide in the C1 lateral masses. So there's nothing off the shelf that allows you to achieve this. You can see the representation here of the tumor, and everything here in green is what we need to remove. And so after this, you're going to need to reconstruct from the superior end plate of C4 to the bilateral C1 lateral masses, and we have nothing off the shelf to be able to achieve something like that. So here is the en bloc specimen of the tumor, the C2 articular surfaces, the dens, and then the exophytic component of the tumor. This little thing right here is actually the vertebral artery, which we ligated and took within the en bloc specimen on the right side. Of course, you need to confirm that the patient can supply their posterior cerebrovascular anatomy through the left-sided vertebral artery. Here's another representation of the tumor. As you can see, we take all of these specimens out completely en bloc without the tumor capsule being breached. But then here's the challenge, the reconstruction of the spine. So we designed an implant that there's nothing off the shelf like this that would allow us to transmit these forces from the superior C4 end plate to the bilateral C1 lateral masses. We designed a little cavity for the implant to fit a structural vascularized fibula for the patient, autograft, and then another basket for allograft on the other side. And here's the implantation of the representation of the implantation on the patient. And this is about 1 year out, flexion extension films demonstrating that he achieved a successful arthrodesis. And this is him, one of the about 3 months after surgery, who's doing well. And this one, because we knew where we were going to land the implant, we didn't need to cut the landing zone. So the implant, we actually were able to design the implant prior to the resection and had it available at the time of the resection and implanted it on the same day. So this kind of puts me in the next phase of this talk. So the challenges of these en bloc resections, they're high morbidity, long operative times, high detailed planning. And as you can see, as we were putting all these teams together in terms of the team that helped me design the 3D printed models to plan the surgeries, the team that was helping me plan the 3D printed implants to reconstruct the patient, the multiple surgical teams for access, the surgical teams if you needed to do a diverting colostomy because you're going to take part of the viscera with the tumor, the plastic surgery team, all these things, and then the trainees, the people who were training to do these surgeries. I realized that it was somewhat difficult to communicate this and plan this. And it's one of these things where you just say, well, if you've done this long enough and you've been around it long enough, you learn it. But I felt that it could be easier, and it also made it difficult to communicate to other colleagues exactly what we're doing for our research. So we developed a framework to build our teams, to plan the surgeries, and to communicate what the goals of the surgery are, and to be able to study it in a more reliable, common language. So we call this framework CLIMR, C-L-I-M-R. And it's really composed of four things. Number one, the spinal column. Two, line of sight. Three, margins. And four, vertebral ring. And I'll go into each component of this in detail here. So this is L2, L3 biopsy proven chordoma in a Jehovah's Witness. So he also went to a few different places and told that an en bloc resection was not feasible because of the risk of blood loss in somebody who under no circumstance would accept a blood transfusion. So we look at a tumor like this and we make this 3D model and we realize that it is quite complex. There's a lot of associated critical vasculature around it, and if we're going to get any chance at resecting the tumor, the most challenging part is going to be able to do so without any type of vascular compromise. So we think of this tumor within the framework that I just introduced. We can start with the column. So the column refers to what part of the spine of the anterior vertebral column, anterior and middle, needs to be resected in order to release that tumor from the patient's axis. And there's a couple of different osteotomies that we can make. And with each progressive osteotomy, the complexity and invasiveness and morbidity of the case increases. And this goes from just a simple sagittal split osteotomy where you're leaving some body behind that's not involved in tumor, all the way non-intuitively, actually, rather than osteotomies, radical discectomies. It's more difficult to cut the disc in the annulus and all the ligaments associated with it to completely release a vertebra than it is to cut the bone. And when you think of it that way, in this case, we obviously needed to do 2 radical discectomies to release these 2 vertebrae. So there we defined in the part of the column aspect of this case, resection of the radical disc at L1, L2, and L3, L4. But what about line of sight? Line of sight was perhaps one of the most important things in this case, because if you perform a posterior only approach, you're going to, of course, see all the tumor boundaries, and you very well may be able to accomplish this surgery completely in a posterior only fashion. These red lines really here denote your line of sight that you're going to have through that posterior approach. But remember, this is the Jehovah's Witness patient. And so vascular injury is going to be extremely poorly tolerated. So really the line of sight in this case that was most critical was access to the patient's anterior vasculature. So in this case, we performed the anterior lateral approach first, ligated all of the segmental vessels, veins, and arteries, and placed this elastic sheath here in blue that you can see to separate the patient's viscera as well as critical vascular anatomy, so that when we performed the posterior approach, we were much more safe in being able to do so. But line of sight can sometimes be much more difficult than that. Going back to that earlier case that I showed you, having access to the upper cervical spine when I trained traditionally involved a transmandibular open French door split to give you access to that upper cervical spine craniocervical junction. But that was really morbid when you split the mucosa and the pharynx. That did not heal well, especially if you put implants right behind it with saliva constantly soaking that. So in this case, we devised a submucosal mandibular split with our head and neck surgery colleagues. This is what this plate is from after they replated the mandible. And we put metal sutures on the mandible, and we would split the mandible apart submucosally so that we never had to breach the mucosa to get access to the craniocervical junction. So line of sight, extremely important. You need access to the tumor and all of the associated critical anatomy. And then margins. Well, going back to our index case that we're talking about here, what margins tell you is not just about, oh, obviously we want negative margins, but really margins talks about what structures do we need to sacrifice to achieve negative margins. And this is a direct impact on morbidity because these tumors are often in very close proximity to viscera, nerves, vessels, etc. And if possible, and if the tumor's in close proximity or invading the adventitia of those structures, you need to sacrifice them. But you need to weigh the sacrifice of those structures with the long-term morbidity associated with that or immediate morbidity, and sometimes it's prohibitive. So we go through these images with a fine-tooth comb with the radiology colleagues, with our multidisciplinary teams, and talk about what is the tumor touching, what do we need to take with it, and can it be taken? And of course, at the end of all this, the pathologists are extremely important in letting us know whether or not we achieved the desired negative margin that we wanted. And our radiation oncology team gets involved ahead of time as well, because sometimes we'll do neoadjuvant radiation therapy to shrink the tumor to give us a smaller tumor volume, so that perhaps we can not be as morbid when we need to sacrifice multiple structures to achieve these negative margins. But this is important because when we talk about this from a research standpoint, the different structures that we need to take can be classified in their order of the associated morbidity that's going to come from the sacrifice of those structures. And you can see here, going all the way from non-eloquent nerves that the patients generally do not miss, with the exception of the occasional pseudohernia or of dermatomal numbness, all the way up to a potential four-quarter amputation, limb sacrifice, if you have something like a malignant peripheral nerve sheath tumor of the cervical spine and brachial plexus. So here's a case that I think represents this concept well. This is a large, giant biopsy-proven distal sacral chordoma, extensive invasion into the abdominal wall and gluteal tissues. So it needed both a sacrifice of the rectum and descending colon, as well as significant muscle and soft tissue around it. You can see the size of this thing when it comes out.
There you go.
Sometimes it feels like we're delivering a small child here.
Good job, buddy.
All right. And so when we think about the margins here, we had to sacrifice muscle, vessels, organs, and viscera. And here's the patient about 6 months after surgery. So the last thing, and perhaps the most critical thing, is the ring. You know, if we think about the vertebral column, no matter where we look at it, is a ring, and through the center of the ring are the neural elements. And we need to open that ring in some way, shape, or form to rotate out the specimen without injuring the neural elements. And how big of a window we have to open that ring directly impacts how risky of a procedure that's going to be towards the patient's neurological function. So you can see, going from A to D here, conventionally, if the tumor is entirely out in the front, maybe a little bit in the pedicles, but you have access to perform a complete laminectomy without concern for breaching that tumor, you're going to have a very conventional big dorsal midline bony defect that you can use to rotate out that vertebra away from the neural elements. And this gets progressively more complex all the way to D, where the tumor may have a near circumferential spread, and all you have is a little bit of a pedicle window to try to rotate out that vertebral body. Now you can imagine, if there's 360 degree spread, then really a true en bloc resection is impossible, and you're talking about a planned transgression in order to open up the vertebral body ring. So in the case that we have here, the index case, we can do that traditional A approach, where we're going to have a big midline defect and the tumor is entirely anterior. But in this case of a biopsy-proven radiation-induced sarcoma, you can see that the tumor has near circumferential spread, and all we have is these little pedicle windows and multiple levels to deliver the spinal cord in this thoracic tumor. That's exactly what we did. So you can see here on the left, you have an axial representation of the specimen with the chest wall involving the tumor completely removed en bloc. You can see here the spinal canal, and then along multiple bodies, we resected the pedicle on one side and delivered the tumor out through that defect, or delivered the spinal cord out through that defect, and you can see the defect that remains here. And there's an x-ray of the tumor specimen, which we've gotten in the habit of taking now, just to document it. So to summarize this climate framework and team composition, we have column, line of sight, margins, and ring. For the index case that I showed for column, we needed to perform radical discectomies. For line of sight, we needed a multi-level and multi-circumferential approach to devascularize the tumor in anticipation of the resection because of the patient's Jehovah's Witness status. In terms of margins, we had to sacrifice an eloquent nerve. We needed to sacrifice the left L2 nerve on the side where the nerve was involved by the tumor, and thankfully it did not cause too significant of a neurological deficit that the patient was still able to ambulate. And then in terms of the ring, we were able to perform a conventional bilateral laminectomy and facetectomy in order to release the posterior elements of the vertebral body in preparation for the tumor delivery. And so here is the tumor specimen. So this is an axial of the disc, the spinal canal, and then the exophytic component of the tumor. And those are the L2 and L3 vertebral bodies together. Here's a reconstruction, and here's the patient doing well. So I'll go through one last case just to bring this all home. This is a 19-year-old female, biopsy proven, MPNST in the upper thoracic spine. She's NF1. Her mom has been taken care of at her NF1 center as well, and her mom actually succumbed to an MPNST. And so they asked us to be as aggressive as possible, given that they had already lost one of her family members to this terrible disease process. So you can see the tumor involves the brachial plexus, is in close proximity and involves the upper thoracic spine, and also involves the subclavian artery, subclavian vein, and the vertebral artery on the left side. Here's the 3D model of the tumor. And so we need to think about this very complex tumor from its anatomical involvement in a more simple way. So we break it down into this framework. Well, column, it actually only touches part of the vertebral body, so I don't need to resect these entire vertebrae. I can just do sagittal split osteotomies and release the part of the bone that the tumor is touching. That part's not going to be very complicated. Line of sight, it's going to be very hard to get access to the upper thoracic spine. If you especially anterior laterally, to have access both in the middle as well as out past the midline. A conventional sternotomy is going to put you right in the middle, but you're not going to be able to look past the side. And you can't do a direct lateral approach like we can to the anterior lateral mid and lower thoracic spine because of the scapula and the axilla. And of course, the great vessels and everything is there. So we devised a special osteotomy. I'll show you what that is. Margins, we're going to need to take a lot of things to get this person a negative margin resection, significant muscle, soft tissue envelope, pleura, ribs, chest wall. So the entire T1 rib is going to need to come with it, as well as aspects of the T2, T3 rib. We need to sacrifice the left subclavian artery, vein, and the vertebral artery. So we needed to confirm that she could perfuse her brain with the contralateral vertebral artery. And our vascular surgery team confirmed that they could do a vessel reanastomosis afterwards, because it's no good saving the nerves and the arm if the arm has no vascular supply. And then we needed to sacrifice some eloquent nerves. We really needed to take every nerve below C7 with the tumor as part of her brachial plexus resection, given that the tumor originated from the brachial plexus, with a later plan to reanimate her hand if she retained good deltoid bicep and tricep function, which she ultimately did. And then lastly, part of the ring, most of the tumor is actually out in the anterolateral space, in the scaling space. So there's really no significant involvement in the canal, so we can just do conventional laminectomy to open up the vertebral ring. So this is the osteotomy that we did. So we call it a sternoclavicular osteotomy, where we used the ultrasonic bone scalpel to resect the manubrium and the clavicle out laterally, kept it in one piece, and that gave us excellent access to the upper thoracic spine, as well as the anterolateral aspect of the tumor, as well as the T1 rib, which we resected in en bloc. This is the radical neck dissection
So
we did to deliver it, and here's the tumor.
beginning with the top of the specimen, T1, T2, T3, the sagittal split osteotomies, the T1 rib in its entire portion, we disarticulated it from the sternum Then the T2 and the T3 ribs were sectioned off approximately a centimeter off their takeoff from the transverse process. And then here we can see the lateral aspect of the vertebral bodies and the tumor growing from them. You can see the tumor is completely involved in pleura and soft tissue here. Here, it's hard to tell, but the little coils coming out through here, that's the vertebral artery. And then the subclavian artery that was going into it was cut, amputated right there.
Here's a X-ray showing the specimen of the tumor and the final reconstruction. So we looked at our preliminary data with these tumors, and inherently, as the different scores for each aspect of the Clymer system, column, line of sight, margin, ring, go up, of course, the morbidity of the surgery goes up, and we see all the associated factors that are show worse in morbidity in the perioperative period, increase longer hospital stays, increased case duration, higher blood loss, neurological deficits, etc. So hopefully I leave you with this framework that can help you simplify as you encounter these cases and how to think about them, how to codify them, how to break them down into a simpler way that makes them easier to tackle, assemble the team that you need to achieve the case, and ultimately how to reconstruct the spine. Thank you, everybody, and here's my email if I can ever help if you're taking one of these cases on, and I'm happy to give you my thoughts and opinions. Thank you.
Good job. Thank you so much. Fantastic stuff.
That was awesome, Camilo. Hey, fellows, you guys got any questions for Camilo?
They're wowed.
Just- Yeah. Hey, just from a standpoint of like when you started doing these, I mean, obviously you're at, a very prestigious university that has, subspecialists much like yourself in so many different like fields. Like, did you tackle these right off the bat, or what was your progression into doing these cases?
That's a good question. So I actually went into neurosurgery because this is what I wanted to do way before I developed this passion for deformity. I got, as a first year medical student, I shadowed Dan Shuba, who was a chief resident at the time, and working with Ziega Koslin and JP Walensky at Hopkins, and this is all they did, and I was like wowed by this. So I was like, I want to do this, and if those guys would have been orthopedic surgeons doing this, I would have gone into orthopedic surgery. But so they became my mentors, and then I did a lot of research in it as a medical student, and then during my neurosurgery training, I mean, any opportunity that I had to be in these cases, I sought it out, and then during my research, I spent extra time working with them clinically on this during my unfolded fellowship. So I felt as good as one could be. You're never really truly prepared for these cases until you take one on your own and take a couple of licks as you build this practice. But I felt comfortable at least taking them on when I first got out of practice. That being said, it probably took, I don't know, at least 2 years until I got one referred to me, because the oncologists are quite protective of these patients, and they have no hesitation to send them out, even if we're at WashU to other places. So it took a while for them to trust our team, and now the oncologists are kind enough, and we keep them, and we're getting external referrals as well routinely.
That's great. Great. I just wanted the guys to hear that, like, because a lot of times you think, hey, I'm just gonna, go out, I'll try to build a tumor practice or whatever. It's takes a lot of work, I think, and dedication, and I like how you tackle it along with the academics of it. I think it's critical, especially in these, it's a relatively rare disorder, right? So to be able to, study sort of these rare diseases, I think is really important to taking care of them.
Dr. Molina, this is Yusuf, one of the fellows. I just had a question for you. You touched on the Clymer scores that you guys developed. Do you ever use that for determining actually whether to intervene surgically versus not, or is this pure just application to operative patients?
No, so the climber score is actually very new. It's in peer review right now, but I think you hit the nail on the head. Um, we surmise that eventually, as we score and appropriately determine the morbidity with certain scores, we might say this is too morbid. Like anytime we do a tumor with this high of a score, people may not make it out of the hospital, or the perioperative complications are just exceedingly high. And in that case, as much as we hate to admit it, we may have to defer to you know um, heavy particle radiation.
Mhm.
So, well, thanks. I know you got a day ahead of you, so appreciate you being.
Well,
Cool.
thank you for having me, guys. Take care. Hope
Appreciate
everybody
it.
has a great day.
We'll see you soon.